Last person to pose questions for this panel will be Mr. Johns for 2.5 minutes.
I'm going to stay on that thread. Dr. Ghosh, you've been involved in the conversations around involuntary treatment. You were on cross-country checkup yesterday. Do you think it's premature to have this conversation when so many people don't even have access to voluntary treatment on demand, like Dr. Patel just talked about? And because I've only got 2.5 minutes, we heard Dr. Zhao from Portugal say that they don't support mandatory treatment. They say it doesn't work. Also, you've talked about incentivization, paying people to do treatment. And lastly, you're a member of the coalition of called Doctors for Decriminalization. Do you continue to believe that criminalization of people who use drugs causes more harm and creates more barriers to recovery? And you've got the remainder of a minute and a half left of my time. So I'll let you speak to it.
Sounds good. For Doctors with Decrim, first off, yes, I do believe that decrim is the way to go. I think the model of decrim varies from the models we've seen of decrim have varied. We just need to find the right model that works. So we shouldn't give up on it yet. So that's number one. Number two, in terms of involuntary treatment, I'm a huge proponent of incentivized treatment in the sense that we know that it works from a medical evidence perspective. We know that ideas such as contingency management has worked really well for methamphetamine use. There's tons of evidence around this. You know that around vaccines, that incentivization has worked as well to get people to take the vaccine. I do think that we can create a system in which we can get people into treatment, provided that there is incentivization. And we've heard this from people who use substances themselves. I do think that that the whole mandated treatment piece, if it, it's very complicated, but we still need more space for people who want to seek voluntary treatment, and we need to build a system up for that first and foremost. That is crucial, and I don't think we're there yet. And we have to have standardization around treatment services as well. And I also do think that in terms of there's like one last part of your question I'm almost forgetting right now, I think. But sorry, Honorable John.
Continue to speak about the involuntary treatment being premature, given that people don't have access to voluntary treatment on demand.
Yeah, and that's the key thing. And maybe the one last point that I do want to say is that outside of there being a lack of access, is I do think that there's a portion of the population that will not benefit, and that is people who are moderate to severely brain injured or have moderate to severe cognitive concerns. It just will not work for that population group, and I think that's where we're looking at when we're looking at people who have substance use concerns on the streets and they're talking to themselves and they're acting incoherently. Part of that is the substance, but part of that is also concerns around their cognition. And I do not think that forced treatment, mandated treatment would work on that population group. We need to have alternatives such as housing for that population group.
Thank you, Mr. Johns. Thank you, Dr.